And whilst you are finishing up this, I'm going to introduce you to our speakers today. Hebe is a Senior Project Manager and the Maternity and Neonatal Programme Lead at the Health Innovation Network, South London. Hebe is a registered midwife and has extensive experience across clinical maternity settings in London and the Midlands. She holds a Lean Six Sigma Yellow Belt qualification and previously served as a governance and quality improvement midwife in a London tertiary hospital, leading multiple clinical QI initiatives. At the Health Innovation Network South London, she oversees maternity and neonatal patient safety projects across South London, supporting clinical teams in sustainable QI practices through leadership, facilitation, and collaboration. Karen is a Senior Project Manager within the Patient Safety Team at the Health Improvement Network South London. She currently leads the Perinatal Culture and Leadership Programme for South London Trust, fostering environments where people feel empowered to drive change collectively. She has been her guiding principle behind her operational and transformation roles. Karen has also worked in healthcare research and national organisations which develop a particular interest in evidence-based approaches to improvement. Karen is a QSIR practitioner, holds an MSc in healthcare leadership, and has been privileged to work with teams on award-winning change programs and academic publications. Thank you very much for joining us today, and I'm going to hand over to you guys now.
Thank you so much, Alex. I'm just going to say a little initial caveat. Unfortunately, Karen was not able to join us today, but has been heavily involved in the development of this workshop. So still wonderful to credit her work. I am instead joined by Zoe Taylor, who is on the call and is working in my team leading the perinatal optimisation improvement project for South London at the HIN. Thank you so much to everyone for coming. We're very excited to be here. We're very excited to be invited by Q to do a talk. We're going to be talking a little bit about our journey as improvement practitioners supporting the South London maternity and neonatal units through the use of a case study of the perinatal optimisation pathway, but this can apply to any kind of perinatal, maternity or neonatal improvement work. We're going to try and generalise it a little bit. It's great to see all of your different sort of job roles in the chat. That will help us to really tailor what we're going to be delivering. So here is our brief agenda. We are very much running to time, which is fantastic already. So the next 10 minutes, we're going to introduce ourselves, but also the work we do and how we are kind of commissioned and how we run things. We're going to do a little bit of interactive work with a Menti tool and a bit of group discussion. We're then going to split you into breakout rooms thrice. So get your interactive brains working with short gaps between for feedback and discussion. Then we'll tell you a little bit more about why we've bothered doing what we're doing. And everything okay? Could I just ask everyone to mute themselves just so we've got not any background noise? That would be great, thank you. And then we should be closed by 2 o'clock, nice and sharpish. Please feel free to put any questions, comments, reflections, thoughts in the chat as and when. We are going to be excited to learn from you guys as well, hear your thoughts on this sort of journey. I'm going to quickly explain what a Health Innovation Network is, because some of you may or may not be familiar. So apologies if I'm teaching you to suck eggs, but we're going to go back to basics a little. So in England, this is NHS England specific commissioning and work. There are 15 Health Innovation Networks. You can see the lovely map here with all of the different logos. We each cover a specific region of the country. Our Health Innovation Network is HIN South London. So we support all of the South London maternity and neonatal units via working with the South East and South West London local maternity and neonatal services, or LMNSs, via the ICBs. We, all 15, are commissioned by NHS England to deliver a specific portfolio of patient safety improvement programmes that have the intended effect of standardising care, standardising practice and improving safety outcomes for patients accessing the services. One of those projects we run is the perinatal optimization pathway. So that's a perinatal improvement project. Zoe's going to go into a little bit more about that later, but firstly, we're going to tick off what we expect the key learning outcomes to be. Thank you, Zoe.
Thank you, Hebe. Yeah, so I'm Zoe. I'm a project manager in the Maternity and Neonatal Patient Safety Collaborative team, bit of a mouthful, in South London. So the session today, we're really hoping to talk about how we work and engage with stakeholders and how to bring people along an improvement project with us. So the first one is about learning effective strategies for engaging stakeholders for successful project implementation. The second one is we want to share with you some of the insights we've reflected on around managing relationship dynamics with maternity and neonatal teams specifically. And while our examples will pull from those specific services, we hope that there's similar learning that might be applicable to your areas if you don't work in or with maternity or neonatal services, although it looks like we've got quite a few people from those backgrounds, so that's great. And thirdly, we want to talk a little bit about how we've gone about and engaged with busy teams in really high pressured clinical areas and how we've been able to get really good outcomes for our service users. And finally, we hope that you go away with some enhanced skills or new ways of thinking about teamwork, leadership and collaboration to bring back into your own areas of work. And like Hebe said, there will be chance for discussion and interaction. So please do turn your camera on if you can and engage with others in those groups. Have the next slide, please, Hebe. So just to set the context for today's session and why we're here, essentially. So for the great majority of service users, pregnancy and childbirth is a positive and happy experience. However, that being said, there is variation in the quality of care that people receive across England, and maternity and neonatal care remains a national and political priority. It has featured predominantly in Wes Streeting's 10-year plan, and there have been multiple national investigations to understand practice and learning opportunities in maternity and neonates. Most recently, you may have seen the government has appointed Baroness Amos to lead the independent. Oh, sorry, someone able to mute themselves. Thank you. To lead the most recent independent investigation, including 14 trusts. And secondly, we know that staff within services are committed to delivering high quality, compassionate care to all. And we know staff and services are continuously learning and adapting to meet the trend of higher demand of more complex care, but requires more complex risk management and intervention. We also know that in 2023 to 2024, 41% of NHS resolution compensation payments were for maternity related claims, which totaled £1.15 billion. So in response to all of these factors, many staff within trusts and other organisations are committed to improving the quality of care. So on the next slide, please, Hebe. This is an example of where those improvement project energy has gone, essentially. So I feel like many of you, based on your job titles, will be familiar with this. So apologies if this is information that you've heard lots and lots of times, but I think it's really useful for those who haven't seen this before to have the background context. The perinatal optimization project is based around reducing and improving outcomes that are based on mortality and brain injury for preterm babies if they're born before 34 weeks of pregnancy. So all of these interventions are evidence-based and have been put into a care pathway that, if implemented well, has proved to improve outcomes, reduce mortality rates, and support babies born prematurely to have better outcomes throughout the rest of their life. We won't be going into the actual clinical detail of what this means, but we're going to be thinking more about how the work is supported from an improvement lens. It would be helpful for you to remember that this is a pathway approach with 9 elements, and to consider that when thinking about how improvements are made in practice in some of the breakout rooms. Next slide, please, Hebe.
Just to add very briefly, if you're interested in the clinical context and the evidence, then you can search for the BAPM Perinatal Optimization Toolkit and you can learn more about it there.
Thank you. Yeah, so this work has come about as a NHS England commission to address gaps where preterm babies were not receiving essential interventions, leading to what would be preventable poor outcomes such as cerebral palsy. When things go wrong, it also opens up that risk of litigation that we touched on earlier, and this has been progressing over the last 4 to 5 years. So we're now very much in the state of trying to make sure these interventions and the processes are sustainable as possible, business as usual, and will be able to be maintained when improvement support is no longer available. The majority of preterm births happen for parents with no risk factors, so it's difficult to predict, and therefore we use a lot of learning from patient experiences in our improvement work. And the hope is that focusing on this work and learning from cases can also try to reduce preterm birth rates and therefore litigation around parents losing their baby or their baby being succumbed to some kind of brain injury because of poor outcomes. So overall, very much rooted around patient and staff experiences of delivering care. And then on the next slide, one of the things we've been doing to support our South London units to embed this pathway is the use of a communication tool pictured here. So to people who haven't been in the clinical environment, like myself, I've been told that when someone is having a preterm birth, everything is very urgent and everything is quite scary and panicky. So it's often hard to impart essential information. I think I'll briefly explain this tool as it'll be helpful background information to have when we go on to the breakout rooms as well. So BAPM is the British Association of Perinatal Medicine. They developed this tool, and it's a baby passport which includes the 9 elements from the pathway and can be used to help clinicians communicate with patients and keep track of which elements have been given. We took steps to translate the tool into 26 of the most commonly spoken languages in South London, because we recognised that a lot of the people that were having preterm births, English wasn't their first language, and they were often from populations of global majority backgrounds. What also contributes to fear around preterm births is that over 50% of preterm births that happen to people who didn't show or demonstrate any risks or risk factors at the beginning or during their pregnancy. And sometimes it just occurs, maybe something hasn't been picked up, or it's just spontaneous. So it's really hard to predict when someone's going to have a preterm baby, and you can't just prepare everyone, because that would also be somewhat fear-mongering, because then it may not happen. So this tool has helped create that more digestible approach at the point of care, and it will often be given to people in maternity triage or when they're told that they may be having a preterm baby. I think that covers it. Hebe, anything else to add on those bits?
I was muted. No, and we are now going to go into the first of our kind of activities. Forgive me while I just share the Menti. So I'm going to pop this on the screen. If you are happy to scan the Menti QR code. Oh, if it's going to present for me properly. Forgive me. There we go. Didn't want to do full screen. All righty. So if you're able to scan this Menti with your QR code, let me put this in the chat as well for you to open on your desktops. Hopefully that link works in the chat as well for you if you need it there. So we want to ask you, in your own shoes, so we're going to use a couple of metaphors in this session. So in your shoes or in other people's shoes. So starting with your shoes, how do you feel bringing about change or leading improvement work? What does it feel like emotionally, tell us what you think. Oh, interesting. Thank you for these.
A real mix there.
Big, fat, challenging in the middle. I like it.
That's not super surprising, I would say.
Does anyone have any reflections on what makes it so challenging? That they want to bring to the room.
Feel free to come off mute and add to the conversation.
Time consuming, daunting. Diane.
Hi everyone, my name is Diane. I'm part of the Practice Education team at Northumbria Healthcare Trust. So I think for me anyway, with service improvement, some of the challenges that I've faced previously is buy-in from senior staff and then buy-in kind of from different stakeholders as well. I feel like you have the service improvement in your head and you know it's going to be a good idea, but it's actually trying to get that across to everybody else.
Thank you so much. Totally agree. Without that executive sponsorship, you're kind of going nowhere fast. Fiona?
Hi there. I think it's kind of sometimes some of the systems within the hospitals and how the leadership structures are within maternity and neonates. I know where I work, it's quite separate. Neonates is under the Children's Hospital, maternity is under Women's and Children's, and then we're, that trying to align and work together in a perinatal kind of way it feels a little bit kind of forced at the moment when the structures aren't really embedded. So I think it's challenging, across the board from that perspective.
Yeah, totally agree. Thank you. The perinatal working isn't always as natural as it sounds like it should be. This is fantastic. Thank you so much for your reflections. We're now going to hop to, it's going to work, the next version. So think about wearing somebody else's shoes. What might it feel like to be on the receiving end of potentially your improvement work, or those times where I'm sure we've all been subjected to not particularly good improvement work or very good improvement work? How has it felt? Just a couple of words. Overwhelmed. Okay. Thank you for these. Confusing, stressful, not inclusive, surprising. Now, again, anyone want to put their head above the parapet and say a little reflection on why might it feel like these words, positive or negative? Diane?
I think if people can kind of see the benefit for their working life in the service improvement, they're much more likely to get on board with it straight away and not feel as overwhelmed by it. But I think if you don't get that and they don't see that straight away, there's more likely to be barriers.
Absolutely, totally agree. And actually that point is pretty much what we're going to be working on in the breakout rooms, following on from this. So that's a really helpful leading point for us. Any more reflections? Otherwise, I think we'll move into the segment of breakout rooms. Fab. So sorry, I'm going to flash about again.
Just while Hebe's getting up the slides, I'll just talk to how we're kind of envisioning these next breakout conversations going. So we're going to almost refer to improvement work as a room. So we're kind of looking at it from 3 different stages. So the first stage is kind of how do you get in the door? So if you're talking about being in the room of improvement work, how do you get that initial buy-in? So your scenario is the local leadership team want to implement the BAP and passport that we mentioned earlier at the hospital that you work in. You need to generate buy-in from the wider team of stakeholders so you can discuss implementation ideas. So the main question we want you to answer at this stage is, what strategies might you use to spark interest and secure time to discuss implementation? I'll just pop that in the chat as well in case anyone wants to copy and paste it. Oh, it's come up massive. Apologies. You're going to have 8 minutes to discuss this. So take it from the view of either in your role at the moment or in the role of facilitating improvement work in the maternity and neonatal environment. Kind of pick whichever lens feels most applicable to answering this scenario. Does that all sound okay?
Great. And then when we return after the 8 minutes or so, we'll just ask for a couple of reflections from some willing volunteers. And then we'll talk to you a bit about how we have done it in the context of this work. Hopefully. Welcome back. Are we all safely transported back into the main room? So we've talked about the scenario. Hopefully you've had some helpful discussions. Before I share with you all of our work, does anybody have any fabulous reflections they would like to share, be it popping your hand up and having a chat with us or popping it in the chat, any key points that answer the question of what strategies might be used to spark interest and secure time to discuss some kind of clinical implementation, safety improvement work? Joe.
Yeah, our group had similar responses, and so it was around articulating the why and why something's important and using different strategies against depending on the stakeholder. So having your qualitative and quantitative evidence and including patient stories and impact of the work, and having your evidence base as well so that you can meet the needs of different audiences and how you can use those stories and case studies from your tests of change to help further engagement and rollout.
Absolutely. That's really, really key. Thank you so much, Joe. Any more reflections? Thank you, David. Workshops to demonstrate the Periprem bundle, identify champions, answer questions. Really, really key, important work to do. All right. So I'm going to move on to how we actually did things, how we got in the door, as it were. So very, very important for us was that we understood the sort of assurance and political and national contexts that the teams were working towards. So, for example, your maternity incentive scheme, how does the work we're doing fit into pre-existing assurance needs? Because 9 times out of 10, you need those assurance needs to help you get your foot in the door, to convince people that it's worth investing time into. So not relying on the stakeholders to tell you about them, being proactive, doing your homework, reading up about those priorities first, so that you go into the room with the pre-existing knowledge of what they are tackling every single day, so that they don't have to spend time educating you. Obviously, you want to hear what their experiences of it is, but you don't want to rely on them to be telling you, we're facing this report, we need to meet these recommendations. That's the kind of context that I would hope improvement practitioners would go in knowing, to then be able to understand the individualized and personalized journey with those contexts. So we do a lot of reading around, making sure we're up to date with the latest national initiatives, recommendations, just so that we're not relying on our stakeholders to have to educate us. make sure you're trying to create really good psychological safety. So the advantageous position that myself and Zoe have as purely improvement practitioners is that we are not there as assurance. We are there as a supportive arm for improvement support. And sometimes having that punitive lens, some of you on this call may have to have that as part of your roles, but being the people that say, we're not here to judge, we're here to help, is a really, really helpful position to be in. But whenever you enter any kind of meeting, be it with really senior stakeholders or with clinical stakeholders, checking the temperature, modeling vulnerability yourself so that they feel safe to be vulnerable with you, talking about confidentiality, sort of contracting if anyone's familiar with coaching, contracting the meeting to say, you know, these discussion points can be really confidential. We're not intending to share them wider. We want your honesty so that we can support you in the most personalised way possible. And meet them where they are. If they've said that they're having an awful day and they've got CQCs just knocked on the door last week, maybe now is not the time to be pushing them on the actions and the prioritisation of this work that's not aligning with that CQC visit, for example, but keeping it in their minds on the back burner as something that they will need to maybe revisit if they've already prioritised it as part of their intentions. Often what we find is we do like to work with the willing, we like to work with the people that have personal interest and passion, but we do need to make this a sustainable improvement. So sometimes finding those people that can have more influence takes making it helping them understand the personal benefit. So, for example, if you're trying to involve junior resident doctors, then help outline that it could be beneficial to their portfolios and their studies, support them to understand because sometimes system improvement benefits are not enough for that individual to feel bought in, which is a sad fact, but it is very true. Sometimes I know if I've been on the receiving end of improvement work, if that doesn't feel like it's going to be a level of personal gain for my role or for my passions and interests, then I'm not necessarily going to be as bought in. And then evidence and impact. In my breakout room just now, they were talking greatly, and just as Joe was, about the why. So what is the baseline data? How is that going to be affected by this potential change? People really, really like qualitative, quantitative information articulated to them as proof of concept. Tangible outcomes are really, really key here. All right. Any further reflections after I've rabbited on at you? Just pull you all back up.
There was one from our group, Hebe, around the securing time that I think we've kind of touched on there with the aligning work to their priorities, but also using the opportunity of core groups with the people in the room that already exist to start that conversation, to be able to kind of articulate those benefits, bring them along from the beginning. When people have so many conflicting priorities, using that time that's already been set aside, I think is a really good tip as well.
Absolutely. Any measurement or any meetings, try not to make new meetings or new measurement mechanisms, try to fit it into what pre-exists, so it's the least burdensome possible. All right. Breakout room number 2. You talked about useful things for yourself. What we were hoping to answer is, during sort of implementation QI meetings, project meetings, what strategies might you, in the shoes of an improvement practitioner, use to continue positive engagement with the improvement project and maintain momentum? Does anybody have any reflections at all? Personal experience of things that have done really well for them in their roles or in their teams, trusts? Absolutely no pressure. Let me move on then to how we approached it. So very much caveating this, that we're in a slightly different position to people that work in just trusts individually. We get commissioning to run positive engagement things and be facilitators of improvement work across numerous hospitals. So one of the things that we find most successful is really outlining our support offer. So we are people that can provide practical support. So thinking admin, action tracking, external accountability for the improvement work to continue. That can be a really helpful thing. So even if you're a improvement practitioner in a trust that's not necessarily tied to one specific clinical team, being that external person that is going to those meetings as somebody that doesn't work in their day-to-day, saying, how is this going? How's the improvement work? There's a level of accountability that the team feel to have updates. Some varying levels of success with that, but we tend to find it has reasonably good effect in our areas. Proactive support is really, really key. So offering check-ins, offering supportive conversations rather than waiting to be asked for them, we find is a really, really good way of being successful. We help to gather deeper insights and understanding into the issues. We find it's easier to build trust and relationships when we can help them to understand the problem that they're trying to tackle. Valuing staff through the investment of time in a system that prioritises productivity and speed. So we spend a lot of time finding the good, complementing the good, and celebrating the good with them, because there's a lot of being trodden down on maternity services and neonatal services in the media a lot recently, with a lot of criticism and people feeling quite burnt out, feeling very sort of apathetic sometimes, and a little bit hopeless about the work we're doing is not working anyway, so why bother? So we want to try and be that encouragement, the supportive people that are saying, you know, you are actually doing a good job. The things you are doing are improving outcomes, even if it's on a smaller scale, but just celebrating the successes with them and for them, and encouraging them to submit things like posters to conferences, to say, you know, this is a really, really good thing you've done. Let's get it out there. Let's talk about it. Protecting relationships and prioritizing communication. So this one, honoring the goodwill is really important. So I often get people from, I don't know, innovations, businesses outside of maternity and neonatal units, that sort of thing, trying to find who is the best person to speak to about this thing that isn't necessarily in relation to the work that they're trying to do day to day and the things that those stakeholders are trying to achieve. And I will be very, very protective of those trusting relationships that I have built. So unless it feels like it will benefit the stakeholder to be in contact with this person that's requesting system contacts, I'll be very, very careful and cautious of facilitating those conversations, making sure that it's in both parties' best interests, not just the person that's approached me for contacts, because often you find that the senior teams in the maternity and neonatal space, it's the same people over and over and over again, and they have inboxes stacked high of people wanting things from them, and they have to prioritize the sort of assurance needs, the reporting needs, etc. Persistence and patience, I think, is the final one. Of it is long haul work. You have to be forgiving, flexible, kind, understanding that even though they've said that they want to do something and the intention is always going to be there, the system that they're surrounded by doesn't always afford that to them, the opportunity to continue with intensive improvement work. It's just not always possible because they have so many competing priorities. So patience, but also kind persistence of, remember this thing that we were trying to do last month, how is it going? Have you had the opportunity to look into this again? Rather than what's the progress, it's was this possible as the first question, not immediately jumping into where are you now, because the truth is that it hasn't always been possible to tackle yet. Before I move on, any thoughts, reflections, comments on what I said? That is fine. All righty. Last breakout room, I promise. So the team are getting excited about implementing the passport, BAP and parent passport, but comment that there are lots of other projects, lots of competing priorities. It might lose momentum and support over time. What strategies might you suggest, support, or use to sustain motivation, implementation, and improvement outcomes? How do you jiggle between quality improvement and quality control? How do you sort of coach the team to get to that point as the sort of improvement practitioner in the room? We are back. They were some of my favourite conversations in the room I was in. Does anybody have any reflections that they'd like to share from that one about sustaining improvement? Really interesting one.
I think Alex said that this is also their favourite stage. So yeah, it's the more satisfying bit, isn't it?
Mm-hmm. Yeah, so Zoe and I are in the position where we'll get commissioned for a medium term financial year, for example, and then there is always the risk that at the end of the financial year we don't get that specific commissioning repeated, and we don't find out till quite late in the day. So always in the back of our mind of the support that we're offering is, how do we set these teams up to be able to maintain this improvement work if we're no longer in that room, and if we're no longer there to facilitate the improvement work to continue. So sustainability is always in the back of our mind from the beginning, from the inception of any project we're working through. Some excellent points in the breakout room I was in around culture change. So all improvement work is embedded around switching the culture from that of a potentially resistant to change to a open to a culture of improvement. That's the term I wanted. Because once you've embedded something simple and you've made an evidence-based change that people really buy into, they then potentially are more trusting that the improvement work further to that are things that are effective, evidence-based, really going to change the lives of patients, for example, service users, but also encompass that service user voice, that people aren't being done unto, solutionized for, changing things to being business as usual. So that was really fruitful conversation. Thank you. So a couple of bits about how we sustained progress. This may be reinventing the wheel for you, maybe telling you what you know, but always connecting it back to the purpose, always coming with data, always showing how we're doing, how much improvement have we gotten to so far? Is this data that we can rely on? Is it valid? Is it helpful? Are we really measuring what we want to? What was the problem we're trying to solve? Is this demonstrating that solution? Embedding actions into the existing pathways and processes again. So real sustainable changes are those that don't add burden to the system. So you're not implementing things that require time above and beyond. You've not got a resident doctor who's working 6 hours on a Saturday to get this improvement work across the line to build their portfolio, but then they rotate out of that system in 3 months because they're moving to a new hospital for a different rotation, but there's nobody to pick up that work. That's an unsustainable practice that can be really, really good for initial momentum, but then once that person is rotated away, completely halts everything and nothing continues because there's nobody to pick up the work that they've started. Wider team relationships, so not just relying on the people that are doing the initial kind of momentous improvement work. It's how do the team understand what is happening, real transparent communication, posters up in clinical areas of this is where we are, this is where we hope to be, getting champions on board, help for them to help to sustain the gains in the clinical areas, for example. Mitigate around timing of exit. So back to what I was saying earlier, there is almost always a time where my team will be moved on to a new priority in improvement work. So we may be coming off of the thing that we were supporting initially. So how do we make sure that the team are prepared for that kind of exit, and the exit from it being an intensive improvement initiative to being a maintained business as usual thing in a state of quality control. As the improvement practitioners, always like to use a coaching approach, so I'm avoiding solutionizing for the teams. It's well evidenced that when you come up with the ideas for yourself in any improvement in personal life, in professional life, if that idea is your own, you are going to be much more bought into it and much more willing to continue that work, rather than somebody saying to you, this is a good idea, you have to do that. There's always going to be a resistance to authority feeling. Most people have that feeling when it happens. So avoiding that solutionizing as an improvement support or facilitator is really important. Calling out the unsustainable practices. Now, this has got to be done with caution, very carefully and very kindly. But if, as a facilitator for improvement, I see the example I was talking about before, a resident doctor who is doing those 6 hours on a Saturday and nobody else is supporting that data collection because it's just, well, they're doing it, so it's fine. Calling out and saying, well, who's going to pick that up when so-and-so has left, has rotated out of that job? And the team will all go, oh God, oh. So it's calling it out early, not allowing those things to manifest into a position where they're irreversible and not rectifiable. And a huge thing around sharing learning. So helping people talk to each other, helping people understand what other people have done in other parts of the country, of the sector, of the trust to tackle that same issue, because it's often approached in silo. We've got this problem, we need to figure out how to solve it for ourselves. But 9 times out of 10, somebody else in another hospital has also come across that exact same problem with a very successful solution. You just don't know about it. So finding those solutions can be a real part of that support. Any questions, comments, concerns, reflections? How are we doing for time? I think we're okay. All righty. Zoe, any thoughts?
No, I think you covered it, and I think in the room that I was in, there was similar conversations. Also perspective from kind of the on the ground work that you can be doing to drive that sustainability, and then also the kind of more strategic strategies you can put in place for long-term almost business as usual type approaches as well. So yeah, I think we've covered it. Hopefully that was useful for everyone to talk those questions through. And we're doing pretty well for time. We're only 3 minutes behind, so
fabulous.
All good.
So forgive me continuing to monologue at everybody. Feel free to stick your hands up and ask any questions or make any comments while I'm talking, but I'm basically going to give you a small rundown of how we've approached this very specific journey of improvement. I'm not going to go into too much detail, but as we were talking earlier, we were mentioning about going in person and not just being somebody on a Teams call. Now, I realise that not everybody is afforded the opportunity because of issues with sort of geographical location and time and opportunity. But in South London, I do have the opportunity to, within about an hour, travel to any of the hospitals that I support from my house or my office space. So made a concerted effort to physically go to meet the people doing the improvement work. I really value face-to-face interactions. Teams always has a place for more regular check-ins, but being physical people in each other's presence, I think we've lost some of that through the process of COVID and moving to a more of a virtual world. But going and visiting people, helping them to see that I am a person who has done this work for a while, who can support them to support their own staff, was really, really important to me. So I went to the majority of the trusts in South London and did educational walkarounds of their clinical areas. We got together snack trolleys, basically bribery, for their staff to talk to them for 5 minutes about the interventions. It was really successful. We covered about 80 members of staff, each walk around, talk to them about the passport, about the optimization pathway, and people were really keen to learn and keen to engage and keen to understand. And it was in situ, so we weren't taking them out of their normal day job to learn about these things. We were going to them, which is a real good opportunity. The other thing that we have the opportunity to do is work with so we are the South London Health Innovation Network. We have equivalents in UCL Partners, who cover North Central and North East London, and Imperial College Health Partners, who cover North West London. So we are the 3 London HINs, as it were. We work together a lot because our London region is managed by the same kind of NHSE maternity team. And so we work very closely with them to bring together a lot of the learning and a lot of the support that we can offer. So in the financial year 24-25, we hosted 5 face-to-face events where we brought together all of the London trusts. It was very much a case of working with the willing, so we advertised it to the system, to the perinatal optimization project teams, but we got between 40 and up to 75 face-to-face attendees by the last event, working through the process of initially what was a passport. Are people open to the idea of potentially implementing it in their hospitals? Does it feel like something that would help? To sharing learning from people who had adopted those things early and were doing pathway approaches, with always having a focus on sustainable implementation of these practices. We then talked about further parent resources. So as a London Health Innovation Network set, we did a service user involvement of parents who'd had preterm babies, and it kind of came out of that we've now produced a supplementary, more detailed information leaflet to the parent passport that we've translated into 26 languages to mirror, off the back of speaking to parents who either knew or didn't know they were going to have a preterm baby, and that was really helpful. Further sharing learning and challenges, achievements, talking to each other, sharing improvement work with each other. We then talked about digital innovations. Some people are using online solutions for this type of intervention. And then the final event of the year was a celebration event where we put on cakes and we got people to share case studies and go up to the front and speak about their improvement journeys, and facilitated them to make case study posters and helped them write those up and make them presentable so that they could share them at other conferences, for example, but really just to celebrate the successes of everyone. And we want to ask, why do we bother? Why does anyone bother with this improvement work? And it's because we get feedback that's really, really wonderful from these events. People felt they had real freedom of speech, that they were able to update each other about progress of improvement work and share learning, that they could troubleshoot and share data, that they learnt fresh implementation ideas for things that they were struggling to solve for themselves, and just learning from each other was really, really valuable. And we know it's going well because we started doing a pathway approach for perinatal optimization about here. This is where HIN support really accelerated from supporting improvement in individual elements, so from optimal cord management, for example, and focusing on just improving that, to actually all 9 elements, we need to improve them as a pathway. So yeah, late 2022, we started that. We can really see, and now this is not crediting just our work, this is the hard work of everybody in the system in South London, but we can see a real acceleration of that improvement work. So this measure is the key 7 elements, I believe, of perinatal optimization for babies less than 34 weeks, and how many babies of the total born are receiving all elements. So the numbers are still relatively low in percentage because it's really hard for every baby every time to get every element, but the huge acceleration. Now this black line is the national average, and we can see proudly that South London is sitting above that national average, near the upper control area, and it's still increasing, it's still improving, and that's down to multiple factors, but we hope that some of that is down to the support and the facilitation that we've been able to offer. And then furthermore, this is the final slide, helpful to articulate the impact of this work. Now, our commissioners kindly create a dashboard that helps us to understand, based on numbers needed to treat, what the potential monetary and economical benefit of this work is. So as of December 2024, so this data is slightly old, apologies, nearly 3,000 women, so which is up to 92% of the total eligible cohort, who were having a baby below 30 weeks, were given magnesium sulfate, which is a neuroprotective drug for the baby once it's born prematurely. This therefore means that up to 61 of those babies born to the nearly 3,000 women will not develop cerebral palsy, which can create a cost saving to welfare and society of up to £61 million. So that was based off of sort of somewhat hypothetical numbers needed to treat, which is 1 in 46. One single case of cerebral palsy costs an average of £1 million to the government, to welfare and society, for litigation reasons, for support for that family. So funding this work and this improvement work has a real cost saving benefit to society, but also life saved, quality of life saved. And then furthermore, by implementing all 9 elements of the optimisation care bundle in London, over 282 lives have in theory been saved in the last 6 years. Now, we don't have the ability to fully say these numbers for sure, because they are based off of the studies of what we believe mortality improvements to be based on the different elements. So it's really hard to say these things for sure, but it's always just good to kind of have a bit of a roadmap of what we imagine the impacts to be and what we intend the outcomes to be based on this work. And that's us done. Zoe, do you have anything to add before we take any potential questions?
No, I think you've just about covered it. I mean, I've come into this project in the last few months. I've been at the HIN a while, but I've been working on perinatal optimization relatively recently, and it's, for me and the improvement work that I've been a part of, it's been a really nice doesn't feel like the right word, but it's been a really nice one to work on, because we do have the data points and we do have the buy-in from stakeholders, and kind of have gone through all of those different breakout room stages that we spoke about. So yeah, that's my main reflection, but I'd love to hear if anyone had any questions or anything else personally. Anushka.
Sorry, this might be out of the remit of HIN, but just a question for you all, because you talked about neuroprotection, magnesium, and looking at outcomes, and we do see all the babies under 30 weeks for neurodevelopmental follow-up. So just as my previous hat as chair of the British Association of Neonatal Neurodevelopmental Follow-up, the NNAP 2-year outcomes are really important. I'm just wondering whether HIN can help in any way to improve uptake of follow-up, because you will need this data in the longer term.
We never say never with these sorts of things. I think as long as we can map it to the needs of our commissioners, then I believe there should be ways we can help. But we do also just need to be cautious of the remit that we've been commissioned to support. So definitely a conversation to explore. We're unlikely to ever say an instant no until we know more. So feel free to get in touch with Zoe or myself and we can have a conversation. Yeah.
Fabulous. Thank you.
Yeah. Pop me an email. I'll put my email in the chat for you.
Any more? Any reflections? I realise we've thinned out. I think the lunch session was good, but people have had to drop off to go back to their normal duties. I'd like to say thank you for the Q team for affording us this opportunity. It's been really great to come and present and share our experience, and hopefully people have learned a little bit along the way. So we're very grateful.
Thanks, Hebe. Shall I jump in there and just say, firstly, thanks to yourself and Zoe for the session today. Really, really great for you to share all those insights and your experience there. And also thanks to everyone else for joining in. It's been a solid long lunchtime session, so appreciate your time and energy here. I think a lot of you noted at the start that this is challenging work. I think it was really helpful to end with a reflection this is also life-saving work. So yeah, big well done to everyone for keeping the energy going on this. I just need to close down really with an ask that you share in the chat any key takeaways or observations that you have. We'd love to hear what your thoughts are on today that you'd like to share with the rest of the group. So if you have a moment and could open up the chat box and pop something in there, then really great to get your feedback there. And lastly, Katie is hopefully going to share a quick evaluation survey that will just help us with our workshop design for the future. We do have one more workshop happening in November, which will be led by Doulas Without Borders. So do have a look at that and join us on the 18th. And I am going to sign off with those comments. But yeah, once again, thanks everyone for your time today. Really appreciate it.